All attendees are in listen-only mode.
Hello, everybody. Good afternoon. On behalf of Fight Colorectal Cancer, this is Andy Dwyer, working here at University of Colorado Cancer Center with Fight CRC. Very excited to actually join us in all for our, at the end of January, our last January webinar, supporting patient education aims through Fight CRC. So we're really excited to go ahead and get started with today's presentation with Dr. Harvey Murff, talking about risk and thinking about risk strategies around recurrence and prevention. So pretty excited to have Dr. Murff on. Next slide. I'm going to go ahead and just note a special thanks to our Fight CRC team, Michael Sola and Sharon, who are definitely helping with all of the back end of today's support, as well as Danielle Burgess and Andrew Wortman in the Twitter social media world, and making sure out to get some good information and facts for all of you. So thanks for the entire team for all of the support to make today's webinar happen. So just a reminder, we're very excited to make this an interactive discussion with, at the post presentation, going ahead and entertaining thoughts and questions. So at the right side of your screen, we'll go ahead and have you type any specific thoughts, recommendations, considerations, questions that you might have for Dr. Murff presenting today, or anything that our Fight CRC team might be able to help with. After the webinar, we do ask, of course, that you spend some time to reflect on how today's webinar went, your thoughts, feelings, as well as any sort of additional perspective about future topics. So in return, the ever-popular I Heart Beauty bracelet will be bestowed upon you upon completion of the evaluation. So we do take this information seriously, need those questions real time today to make this as a fruitful experience as possible for everybody. Following along on Twitter, hashtag CRC webinar for those of you who are on social media today. Next slide. A quick note, we're very excited to let you all know that the new Guide in the Fight is now available online for download. We have taken a lot of feedback from a lot of the survivors, caregivers, and folks in the community around updates. And we've actually broken this guide into 3 distinct sections now for ease of management of use and reading. Very excited about the updates that are definitely included for all of the help and support during and after treatment. And a special thanks to our medical advisory committee, as well as a number of survivors who gave really good time and feedback to make sure that this is a pertinent and fantastic guide available. So one of most Fight CRC's most popular guides, definitely available on our website. And of course, the Tabooty podcast series to complement the webinar and educational programs. I'm very excited with all of Sharon's leadership and some fantastic perspective around topics that are taboo or oftentimes not spoke about that should be. So join us for the download and Fight CRC website for both resources. Next slide. Just a quick disclaimer, just as a reminder that this information, today's webinar, is to use in education to help support your journey and path, but in no way is this supposed to actually replace medical care. And at any time, if there's an emergency, we please ask that you dial 911 and get in touch with your medical team directly. So with that, I'd like to just say a few words about Dr. Harvey Murff, who's been a supporter of Fight CRC over the last year, joining us in Nashville at our 1 Million Strong event, and definitely been a leader in helping frame a lot of the perspective around risk and helping us share a little information about risk reduction and how to thwart reoccurrence, as well as thinking about prevention strategies. So Dr. Murff comes from us from a public health background in medical, an associate professor at Vanderbilt University in terms of working in medical residency at Mount Sinai Center in New York, with his fellowship in internal medicine in Boston. In terms of a professional health degree, Dr. Murff definitely spent time as an expert in the Harvard School of Public Health, and I know that a number of our colleagues in here in Colorado and the like really respect his input based on thinking about cancer prevention and impact of genetics as well. So we're really excited with the work that he's done in terms of the VA hospital and a lot of the research initiatives, and then all of his work at Vanderbilt University to support patients, that he's joining us today to talk a little bit about the strategies in terms of risk and risk reduction. So with that, Dr. Murff, I'm going to hand it over to you, and again, thank you so much for all of your great work, and excited to hear your perspective today.
Great. Well, I'm really excited to be here, and thank you for inviting me. I'm assuming everybody can hear me well. So I am as you mentioned, I'm a general internist, so I spend a lot of time thinking about prevention, and I've also done public health research, so I like to look at the data that we have on here and kind of carefully scrutinize it. And as we go through the talk, I'm going to try to kind of give you, as consumers of medical information, some pointers, or at least some framing how this evidence often gets generated. But what we're going to be talking about is primary and secondary prevention of colorectal cancer. And so to begin with, we always like to begin with a slide kind of framing the problem. And this is a slide that the American Cancer Society puts out about every year. They update it for every year, and it just gives us incident cases, which just means new cases, as well as deaths associated with different cancers. And as you can see, colorectal cancer has remained pretty much where it's been for several years, which is about the number 3 as far as incident cases in both men and women. And then it's number 2, and that's because we see prostate and breast, but the breast is only in women and prostate only in men. But when you combine the colorectal cancer with the genders, it's the number 2 most common cause of death from cancer. So despite being in the age of screening interventions that have been extremely effective, we still have a substantial amount of morbidity and mortality associated with colorectal cancer. So there's a great deal of interest in finding things that might modify that risk, particularly things that we as individuals could implement on our own. And this slide is also comes through the American Cancer Society, and it just shows that over the last 20, 35 years, we've seen a nice decrease in colorectal cancer rates in both men and women. This is very good news. We want to see that continue to go down. And this is thought to be largely related to screening, which is thought to explain maybe about 53% of it. But a sizable chunk, about a third, is thought to be related to changes in some of the risk factors, some of our own habits as a population that has changed over these years. So one thing that I do want to talk about before you get into it is, since we're going to be talking a lot about risk, it's important to define what we mean by risk. And risk, particularly the risk, the way it usually gets presented when you think about an article you might see on the internet or in the newspaper where it says this study found this amount of risk associated with something, versus the risk you might hear when you're actually face-to-face with a health provider. So one type of risk is absolute risk, and this is the type of risk that is more relevant to an individual. This is the type of face-to-face. I'm talking to my doctor or nurse practitioner, and I'm asking them kind of what's the chances of this. And so it's basically just the chance of developing some type of an outcome of disease over a certain period of time. Very relevant. It's a 1 in 100, 1 in 1,000, 1 in 2,000 type case. And often this is the one that that's most important to us as individuals. Relative risk tends to be the risk that you hear the most of in news sources, and that's a lot because that's the way that we conduct these studies, and I'll talk a little bit about that in a few more slides. But what relative risk means is you're really comparing people who have a higher amount of a risk factor compared to those who have a lower amount, and see how that might impact developing some type of a condition. So it's important to know 2 facts about relative risk. One is, who are you comparing? And generally, and I'll talk about this again, we're looking at folks who, if we're thinking of a certain exposure, let's just say, some type of a dietary factor, and we look at folks who maybe eat the most of it compared to folks who rarely touch it at all, and that tends to be where we're doing our relative comparison. And so that's how relative risk gets described. Relative risk, though, is important to, when you think about it and when you hear these numbers, they'll say like doubles your risk or triples your risk. It's important to know that relative risk is really, you must know it in the context of how common the actual outcome is. And I'll show that on this next slide just to give you a quick example. And this is the only real numbers that will be on here, so don't worry. It's not going to be a extremely dry and boring bunch of math. But on the top, this top number will say if we had let's say a disease and it affected 1 out of 10,000 people, and then compare these folks who barely, let's say, eat oranges at all, and then we compare these folks who tell us that they eat oranges 10 times a day, and we see that they're 2 cases in every 10,000, what we get is a relative risk of 2. So you could say, hey, this doubles your risk of this outcome. But when you think about it as an absolute case, what you're seeing is really an increase from 0.01% to 0.02%, and in general, you're just seeing one additional case as a result of this risk. So that's why it's important to know the absolute, how common something is when you hear the relative risk, because in some situations, although that relative risk may be large, and we'd consider 2, which would be a doubling, to be significantly large, it may not have as much an effect. Of course, in this example, where you see a condition that's much more common, 10 in 10,000 over 20 in 10,000, you're seeing almost 100 additional cases, but it's the same relative risk. So when we talk about, throughout this talk, a lot of what I'll be describing will be relative risk, but it is important also to kind of put that in the context of the condition that you're actually talking about. So what are the risks in general of developing colorectal cancer? And whenever I talk about colorectal cancer, it's also important to, I think, spend a little bit of time also describing adenomas, which are the precursor lesion. And we know that adenomas, they have a prevalence of anywhere to up to almost 50% in individuals once they get over 50. And we know that because of colonoscopy screening. It's usually individuals over 50 that we're more likely to screen. But when you look at that much larger pool, a smaller subset, maybe upwards to 7%, will have advanced pathology on it. So it won't be a cancer, but it may be what's called dysplasia. And then a smaller subset of that will actually have when they remove the polyp, they'll see cancer, and that's about up to 0.6%. As far as colorectal cancer, as you can see from this chart, as you get older, your risk of developing colorectal cancer goes up substantially, particularly in the 69 up to 70. But here we give you your absolute risk, where you're looking at individuals who are younger. It's less common, 1 in 300, but it's not. It certainly it occurs, as well as up to going up to over 70, where it can be 1 in 27. So risks do go up as we're seeing over time. Now this chart would be mainly people who are at average risk. When you look at people who have a family history, all of these numbers can get substantially higher. Somebody with a first-degree relative, you could double this. If you have multiple relatives, you could almost multiply it by 4. So we're going to talk a lot about prevention today, and in prevention it does fall into 2 categories. There's primary prevention, which is what we talk about when we're trying to prevent something from ever occurring, as well as secondary prevention, where we're looking at trying to either reduce the impact of, let's say, a cancer that's been detected, or perhaps treating something at the early stage. And in colorectal cancer, oftentimes adenoma, factors that affect adenomas, so sometimes be placed in a secondary prevention rather than primary. But I think in this talk, I'm more referring to it as primary. So before I get into actually what is the data out there, it's kind of important to really go over how medical evidence is generated. And this is also going to sound boring, but I won't spend a lot of time on it. But it's really important. So again, as you read these papers or websites, and you'll hear about this study and that study, you really want to know how that was generated, so you kind of know the weaknesses of it. Sometimes that's not really conveyed in the small blurb that might get the headlines. And this is a commonly used kind of diagram that's used to kind of quantify the degrees of how important medical evidence is. It's a pyramid, and at the bottom is what we kind of consider the lowest levels of evidence. And as we go up, we get to what we think are the better quality evidence. And I really want to have you pay attention to this little block here, because as I go through this talk, most of what we're talking about is going to come from these 3 sections. At the bottom is what we call a case control study, and I'll talk very briefly in a few slides about what that means. But the case control study is, they're relatively, when you look at studies, cheaper to do. So as a result, we tend to see more of those than almost anything. As you also notice, they're kind of here on the bottom, which means for reasons of the way they're set up, they tend to be more susceptible to factors that might make us think what we found is true when actually it's not true. The next level comes what we call a cohort study, and I'll tell you there are folks who do cohort studies who will never give any credit to a case control study. I'm not quite that extreme, but feel like because that level of evidence is a little better. But then what we really like is what we call randomized controlled trials. These tend to be a little bit higher quality evidence. But as you'll see, as we move up this ladder, you could also almost put, as the quality gets better, the expense gets way up, and so we tend to get fewer randomized controlled trials, fewer cohort studies. And finally, what we have up here are means to take this evidence, maybe multiple clinical trials, and try to synthesize it, pull out what they think is the best, and kind of give you a summary of multiple studies. All that being said, is even these, which we'll put on the top of the pyramid, may not necessarily be the best evidence. These are like what we call a meta-analysis, where you'll take multiple studies and kind of put them together to see if it shows you something. And the reality is that sometimes if what you're building your meta-analysis are low-quality studies, it may not be the best study. But so this is what we talk about, and a lot of what I'm going to talk about in this study, particularly when we look at lifestyle and dietary interventions, tend to be data that's come from these studies. So we mentioned it, as I showed you that pyramid, at the bottom of the pyramid is those studies, the reason they're at the bottom is they're more susceptible to things that might make your study kind of fake you out, make you think your study's positive when in fact it's not. And so when I read studies, kind of as with my epidemiology hat, I always try to think of, well, can I see this in the study? Because I may not be able to believe what it is. So when the headline comes out and says, we found that this factor is associated with this % risk reduction, you kind of have to start thinking, well, what could have been done that would have made them find this result when it's not actually true? And a lot of these observational studies, not controlled trials, where we let kind of people do what they do, are very susceptible to different types of biases. And a bias just means that there was something done incorrectly in the study, not by, not deliberately, but some type of error that was done in the study, whether it be from how people were put in the study to whether it be how they measured things in the study, but it was done repeatedly and affects the outcome. Confounding is another important factor, and I'll show you an example of that in a slide, where we think we found a factor that may be important, but actually it's just kind of a passenger with something else that is actually more important as we're linking this risk factor to the disease. And then, of course, everything is susceptible to chance, which means we just happen to grab a population and just happen to have a chance finding that suggested it was positive or negative. So just to talk about the bias real quick, and then we'll move on to what the studies show, is there are lots of bias. There are people who've made their whole career trying to kind of categorize every single bias there might be, and they have lists of 30 or 40 of these. But really, from our standpoint, the most important have to do with how they pick up patients, which we call, or people who are going to be research participants, which is called a selection bias. And that, a great example is, a lot of times if I'm interested in studying a disease, let's say colon cancer, and I want to try to find people who have colorectal cancer, certainly in the early days before better treatments, there was a lot of hospitalization. So maybe I'll go to the hospital to find my cases, but then I want to compare it to a group, and I might find my controls by mailing, sending out letters out to the community. And the problem comes is that the people in the hospital may be different than the people you picked out in the community. So that's called selection bias, and it's much more common in these case control studies. The other one is to talk about recall, which is where the information is. And this is another bias that we see a lot in these case control studies, where because somebody has the condition, they're asking them about things you might have been exposed to a long time ago. And somebody who, let's say, has been diagnosed with a certain cancer, if they've read in the paper that somebody believes that this dietary factor may be related to it, they might be more likely to recall having that exposure than opposed to somebody who doesn't have the diagnosis. It may be more likely to slip their mind. And as a result of this kind of recall bias, something looks stronger associated with like a risk factor to a disease than it may actually be. And in fact, typically when we look at studies that are done this case control, and then they go to this cohort design, and you look at how strong this risk factor was, it almost always goes down, where it looks stronger in the case control and then starts to go down in the cohort study. Now, on the other side, I'll just show you a quick example of confounding. This is very dated, but I don't think I've ever seen an example that's better to explain it. So if we're interested in what causes lung cancer, and for some reason we decide we think matches are, well, if I did a study and I enrolled all these people, I would find that people who have matches well, of course, this, again, has to be before the lighter day, but people who had matches would have a higher risk of lung cancer. Well, of course, we all know that's not true. The reason these are associated is because it's folks smoking who just happen to be carrying the matches. So this pretty much explains confounding, where we are identifying a third factor as opposed to what we're interested in, this risk factor and this disease, that doesn't really have anything related to causing the disease. It's just kind of like a passenger. And we get overexcited about it, and we spend all our time, and then we tell everybody, you got to throw away all those matches, you got to throw away those matches, when in fact we've missed what is actually the causal factor. And confounding can be quite a big problem with any observational study, which would mean it's not a clinical trial. So going back to this pyramid, we've talked about the case control and cohorts. And just real briefly, the way a case control study works is we take initially people who have been diagnosed with a condition, we identify a group of people who haven't, and then we kind of interview them both to say, well, what might have you been exposed to years ago, or this, that, and that, and that, and try to look to see if we see differences. While the cohort, the reason why a cohort is thought to be a little stronger design is we take folks who are healthy and just have them fill out surveys, let's say, and say, this is how much I eat of this, and this is how much I drink of this, and this is how much I smoke. And then we'll follow them over a long period of time and see whether they develop the outcome we're interested in. Both of these are going to be associated with that confounding. So you may have picked the wrong thing to study. But the case controls tend to be on the lower level because they have a little more problem with bias. So that was, in a brief nutshell, everything I think to tell you kind of epidemiology and to just kind of give you a grounding on how strong this evidence is. As I go into some of these studies related to different, kind of dietary factors and things such as that, just remember that a lot of this comes from these case control studies and cohort studies that are not always replicated when you do it in a control trial. And finally, the randomized control trial. Well, why do we like these so much? Well, one is because you flip a coin, so you put people either get the intervention or not. And when you do that, these confounders, these issues that may be related to the exposure but aren't related to your chance of getting the disease, they should pile up evenly on both sides. So in other words, we've eliminated confounding. If it's a big study, if it's a small study, a small number, let's say they only have 100 people, you may not do that. But these big studies, you can say, hey, we've gotten rid of that confounding. It makes it a stronger study. When we talk about double-blind placebo control, when the person running the study doesn't know what you're getting and the person on the study doesn't know what you're studying, that adds another level, getting rid of any type of bias. Well, I kind of knew what I was getting, and it makes me, maybe answer this questionnaire a little differently. And then finally, when we look at an outcome that's what we call a hard outcome, it's something like the diagnosis of a cancer or something like that, something that's hard for two different people to look at and have a different opinion on what was going on. So randomized controlled trials are a lot better. I'll tell you in a little while we don't have as many as we might like. But just to let you know that even though we think it's a lot better, it's higher up on that pyramid, they can also be misleading if they're not done well. And I'll give you an example of that when we get into some of the other issues. So here's the question. Where are all those randomized controlled trials? We say they're the greatest thing, at least for generating medical evidence, and they're very good. But the problem is a lot of what we're interested in are lifestyle and behavioral things, things you may change in what you do on a daily basis, things you may change in your diet, activity maybe. And these are really hard to do in a randomized controlled trial. One is, remember what you're trying to do is you're trying to get one group to do this intervention and another group not to. So often you'll have a thing that's called contamination. So if I'm interested in studying, how much people follow this healthy diet pattern, I may be a participant in the study, and they may have said, just eat your regular diet. But then I'm kind of thinking, well, why are they studying this healthy diet? Maybe I'll just start eating the healthy diet to begin with. And what you start seeing is the people that were supposed to be in the placebo arm are actually doing the intervention. So it's contamination, which can be difficult in these type of studies. It's not just hey, you take this pill and you take this pill. Also, a lot of lifestyle factors, and as I go through the study, you'll see they have an effect, but it may not be huge. So when it's a smaller effect, you got to get a big study. So you can imagine a big study where you get 10,000 people and you try to get 5,000 people to do maybe be more physically active and 5,000 not. It can be a logistically challenging study. And colorectal cancer, for one, has one major challenge is that we know that the disease process can take 20 years to develop. So what we really want to look at is whether this change in your diet or this change in your activity level will reduce your chance of dying from colorectal cancer. That's what we want to know. And because of that, because of the duration of the disease, it would mean that these trials would have to go on very long. And you'll see as I get in the topic and start talking about individual exposures that a lot of times if they have a randomized controlled trial that didn't seem to be effective, the excuse is usually, well, it was too short. And that could be a legitimate excuse. And finally, these can be expensive. So let's talk about primary prevention first. And primary prevention, I've got to break it down into a couple of categories. We're going to talk about screening, some diet factors, physical activity, body weight, alcohol, smoking, and certain medications. And I put screening in primary prevention, although as we had talked about at that earlier slide, it's fair game to say, well, maybe this is the secondary prevention, only in that you'll be detecting an adenoma, which we would consider maybe a precursor lesion. So we'll start off with screening, and screening has had several randomized controlled trials that have shown that colorectal cancer screening through multiple different mechanisms can reduce your chances of developing colorectal cancer and also reduce mortality. It's beneficial because it can remove adenomas, which are precancerous lesions. And as I'd mentioned earlier, when I showed you those curves at the second slide that shows that the rates of colorectal cancer have been going down, it's thought that the lion's share of that is really related to screening. And there are lots of different screening. I took this slide from a very recently published study, but you can just see it's kind of gives you a list of the many different screening options. The reason why there's so many is because to date, there's not one that we can reliably say is more effective than the other. And what's very important is to get people screened. So you like to have a lot of different options, as in one may be more appealing to one individual versus one that's the other. So we don't want to limit that. But I'll just show you what the ones that we have randomized controlled trials, and this, as I said, is the highest level of evidence, really has to do with stool guaiac testing. That's looking for blood in the stool. Whether you use the guaiac-based or imeo, this kind of looking for myoglobulin, the FIT testing. Flexible sigmoidoscopy has also been shown. Flexible sigmoidoscopy because it is relatively easier, I guess, to do than a colonoscopy. It was easier to study, and so we had some RCTs, randomized controlled trials on that. There's some DNA testing out there for fecal DNA that has not really been studied in this setting in the randomized controlled trial. And colonoscopy, believe it or not, which is what is on every screening list, and actually the preferred screening modality by the American Gastroenterology Association, has never been studied in a randomized controlled trial. We feel like we've used cohort data, which has been convincing, and also we know that if you go back to these studies that have shown a significant benefit, let's say like the guaiac study, the reason it showed a benefit is because these individuals who had positive tests went on to get a colonoscopy and have the lesion removed. So we feel like there's enough there that there's not necessarily a need to have the randomized controlled trial for colonoscopy. But as you can see, when the effect on cancer mortality is pretty substantial when you look at colonoscopy here at 68%. And then we have some other modalities like CT scan and then some DNA testing. Of course, screening, there are some limitations. Right now, it looks like about 60% of people who are eligible to get colorectal screening actually get the screening. That number has been kind of hovering at 60 for a long time, and it's been challenging as, you know, in both the multi-advocate community as well as in the kind of health provider community to try to get these rates up, and they just don't seem to want to budge. But there are some limitations to screening. And we talked about colonoscopy, which has to usually is associated with sedation. There is a rate of having perforation and other complications, although it is small, and it tends to be more expensive. So there are limitations. Although this is the preferred strategy by the AGA, there are some limitations to it. I just give a list of some of these other ones. CT colonography has an issue with finding other lesions, which you may not know what you're supposed to do. Flexible sigmoidoscopy only covers part of the colon. And then there's limited sensitivity for the guaiac testing. The FIT testing is a little bit nicer in that you only have to do one test, and you don't have to worry about your diet like in these guaiac ones. But still, there is some variation in how you quantify it. So let's go into some of the other factors outside of screening, and mainly in lifestyle changes. So what is the appeal of lifestyle changes? Well, I think from my standpoint, being an internist, the biggest pro is that you'll notice when we talk about multiple conditions that these lifestyle changes seem to be beneficial for heart disease, for other cancers, for neurological diseases. So although they can be difficult to implement, and in some cases when we look at the data, they don't seem to be this huge magic bullet, they're going to affect a lot of different conditions, including which colorectal cancer is included in there too. So in diet, what I've talked about for this study is, for this talk, I really have only a few categories where I felt like there was a pretty big body of data to pull from. There are a much longer list of dietary factors that we could list that have been studied in the setting of something that might prevent colorectal cancer. But generally, a lot of times, things not on the list may only be a couple of studies, and so we tend to like the totality of the evidence. Like, so if you see something that has been studied repeatedly and you get the same finding, it makes you a little more confident. So fiber is what I'm going to start, sir. And you've all heard, I'm sure, about increasing dietary fiber. And where does this data come from? And most of it, the bulk of it, which was originally kind of advocating the use of dietary fiber, comes from, again, these observational studies. Now, when I have this list of 25 studies, what I'm really talking about are the more high-quality cohort studies. These aren't the case-control studies. There have been probably 100+ studies that have actually looked at fiber in some degree using these different designs, but when you try to narrow it down to ones that we think were relatively free of bias, then you get to a smaller number. But when you look at this most recent meta-analysis that had these 25 studies, they suggested that if you had 10 grams of fiber a day, it could reduce colorectal cancer by 10%. Now, this 10% is again, a relative risk. So what they're comparing, these folks, they'll take a whole bunch of people in the study. They'll ask them how much food they eat and how much fiber. They'll take the people who eat the less and compare them directly to the people who eat the most. So these are comparing 10 grams a day are the people who are eating the most fiber compared to the people in this study who ate the less. So they did see that you've reduced your colorectal cancer by 10%. And to give you some context, that's about eating 10 slices of whole grain bread a day, or 3 to 4 cups of wheat bran cereal. So sometimes as we look at this, we start to find interventions that, although might be beneficial, could be hard to implement because that's a lot of fiber. But for fiber, there's actually been randomized controlled trials. Now, the randomized controlled trials, because of, as we talked about before, this long duration that it takes that we believe to develop colorectal cancer, they looked at adenomas, where you could follow a group of people for only about maybe 3 years and have enough events. So in the studies, there are actually 3 studies that have looked at fiber. Some of them have given people more dietary fiber, some of them given fiber supplements, and those all turned out to be null. So why did we see, what's the difference? Why are we seeing this result here from all these observational studies versus nothing in the randomized controlled trials? And some of the issues that have been brought up have to do with the type of fiber. So fiber is a big category that includes a lot of different things, soluble, resistant starches. And so it's unclear if there might be one particular type of fiber that's more beneficial than the other. There's definitely different outcomes. Here we're looking at colorectal cancer, and here we're looking at adenomas. And then there's always issues related to confounders that might be involved in the observational studies. And it's a good point, just as we talked about confounders, to remember that we tend to see healthy habits all clustering together. So the people who tend to have the healthiest diet also tend to be more active, also tend to be less likely to be overweight, and also tend to have healthier habits with regard to engaging with the healthcare system and smoking. So that's where we get to these problems when we talk about confounding. So we're just looking at one aspect of what tends to be an overall healthy lifestyle. So how about fruits and vegetables? We do all hear about eating fruits and vegetables, and how might that impact as far as prevention of colorectal cancer? Again, when you look at actually eating fruits and vegetables and not necessarily the fiber and antioxidants that might be considered the beneficial part, this mainly comes from observational studies. And in general, why we think it might be beneficial is, as I said, antioxidants. There have been some studies that we'll talk about in a little while, specifically giving antioxidants in pill form, not in the diet, mixed in the kind of the fruits and vegetables. But in general, the estimated effect size, again, the relative risk is like about a 9% decrease. And again, every time we talk about relative risk, almost all these studies take the group of people in this big population that ate the absolute most and compare them to the people who ate the absolute least. Again, this 9% was not really considered statistically significant, although when they looked at sub-analysis, they thought, well, maybe fruits and vegetables may have more of an effect on the colorectal cancers that are diagnosed in the distal. That means more kind of in the descending colon. So red meat is it was come up and received a lot of attention, I guess, last year, in processed meat. And this data comes almost exclusively from observational studies, again, and of course animal studies. And again, not even, and a majority of the studies, 2/3, but not even all of them have found this association where people who report eating more processed meat, more red meat, might tend to have a higher relative risk of developing colorectal cancer. And in fact, the World Health Organization, I guess in 2015, actually classified processed meat, not red meat, as a group 1 carcinogen. So why might this be true? Well, for processed meat, they're involved with nitrates and some other chemicals which we know in the lab and in animal studies are carcinogens. And at least red meat, it's thought right now it may not necessarily be the red meat so much, but the cooking. When you cook it at a high heat for a long duration, you get these polyaromatic hydrocarbons, and they kind of cause problems with your DNA replication, which could be a kind of a subset to this initiating event to colorectal cancer. So there seemed to be animal studies and observational studies. There were a lot of controversy on them making this call, with a lot of people thinking this might be a little premature because we don't have randomized controlled trials. In fact, it would be hard to actually do these. There has been one large study called the Women's Health Initiative, which had a sub-study where they randomized women to what was called the healthier diet. And in the healthier diet, they did eat less meat. But over the course of this study, they didn't see any effect on colorectal cancer. So at least the one clinical trial that might be relevant to this red meat didn't seem to have an effect. So the jury's still out. All that being said is, based on the studies that have been done, there was about an 18% increase in risk for the group that ate the most processed meat, red meat. And giving you the context, when you look at smoking and lung cancer, for the red meat, it was about an 18% increase. For smoking and lung cancer, it's in the hundreds. In fact, it's almost, in some studies, it's like 200s. So this is an increased risk. It's moderate. And I translated that to basically if you ate 2 to 3 strips of bacon daily for 10 years, that would probably result in 1 additional case. Now, all that being said, I'm not here because I'm like secretly working for the red meat companies or anything. Just trying to put it in context. There are lots of other reasons why you'd want to be careful with red meat also, given cardiovascular risks and other issues, blood pressure, things such as that. So, but I'm just trying to put it in context as you're trying to if you're thinking of risk prevention strategies and things that might require a substantial change for what you're doing. But I think there's a lot of health benefits, so don't think I'm getting like Oscar Mayer funding here or something. Okay, so fish. So where does this data come from? So fish studies, we've heard a lot about omega-3s. This is actually where I do most of my work, but I won't spend a lot of time on here. But a lot of this has come from observational studies. And in these observational studies, what they have is they ask somebody to tell them, how much fish do you eat? And they write a questionnaire and they fill it. And as you can imagine, these are challenging to interpret because different fish have different amounts of omega-3s. Believe it or not, tilapia has about the same amount of omega-3s in it as chicken. So there's very certain species that have a lot more of these omega-3s than others. So some studies have used biomarkers. So they measure your blood to see how much you get exposed to these omega-3s, but there are a lot fewer of them. As far as clinical trials, the only clinical trial so far that's been done looking at these omega-3s were in patients who had a genetic syndrome, familial adenomatous polyposis, and they did reduce the number of adenomas in these folks. But whether that's applicable to sporadic, it's unknown. There are clinical trials underway, so we may have some evidence, more solid evidence to guide people. It's believed that the omega-3s work similar to aspirin with an anti-inflammatory effect. The effect size can be anywhere from 12%, which we've seen in diet studies, 40% in these biomarkers. But I would give you a caveat here that there are very few biomarker studies, so it's very early. How about vitamins and minerals? Folate received a lot of attention. Folate comes from dark leafy greens, broccoli, asparagus. In the observational studies originally, it was seen that there seemed to be a benefit. Clinical trials, again looking at adenomas, found that folate was either null or folic acid was null or even may increase your risk of polyps. So this was very confusing to a lot of folks and saying, well, why is there this difference? Again, it might be because whether you're getting folate, which is what comes in the natural foods you eat, versus folic acid, which tends to be the supplement. The timing seems to be important. There is some thought that early on, before people have polyps, folate might be beneficial, but later on, when you might already have a lesion, it might actually promote cancer growth. And then study design. So folate kind of got pretty quickly backed off. Vitamin B6 is another vitamin that's been looked at, again, only really from observational studies and not that many. But again, if you look at kind of a summary of them, it's estimated that you may have about a 10% relative risk reduction. Magnesium, I put it on here, but there's very limited data on magnesium. Only a single study reported in women. Now, calcium in dairy, there's been a lot more work on. And so calcium, we went a lot of observational studies. The risks seem to be, at least in the observational studies, more associated with milk as a dairy form as opposed to cheese and other forms. But we've had clinical trials, and these are calcium supplements. And in 3 randomized controlled trials where we look at adenoma recurrence, you see a good 20% reduction. So there's pretty solid evidence to suggest that calcium may reduce your risk of adenomas. There's been one study that looked at cancer, which was null, colorectal cancer. However, it's important to know this gets back to, as we talked about earlier, these crossover effects. So when this study was done, they gave one group calcium and the other group placebo. The group that was in the control arm was free to take calcium if they wanted to, and over the course of the study, a sizable amount of them actually started taking calcium on their own. So at the end of the study, there was so much crossover that it would have helped minimize some of the effects. So it was very hard. Subgroup analysis, which you have to realize, or subgroup analysis, you can't put too much into it, suggested that in women who didn't take supplemental calcium on their own, it looked to be effective. But for the most part, when we look at the one big randomized controlled trial of calcium in cancer, it was null. Not really sure why calcium works. They think it might bind to bile acids. Where it's still, as far as the jury might up on what happens with colorectal cancer, although the adenoma data looks pretty convincing. Vitamin D, again, comes from observational studies. One clinical trial of a randomized control trial looking at cancer was actually null, but it was thought that this was a very low dose. So we have currently studies ongoing using a higher dose. And this is lots of different mechanisms. And before I move on there's been a couple of randomized controls of other antioxidants, vitamin C, vitamin E, selenium, and beta-carotene in a randomized control setting for adenoma prevention, all of which, at least in the randomized control, were null. So how about physical activity? So again, this comes mainly from observational studies, just because it's hard to know how much physical activity you can, it's harder to do this in a randomized study to actually, if you can imagine telling people don't exercise, it's probably unethical to do such a study. All that being said, we have no idea why it works, but it looks like it's very effective at reducing the relative risk. So again, comparing people who exercise pretty regularly versus people who don't exercise, it says that this almost 30% relative risk. And as I list here, these are all the conditions that looks like physical activity presents. So certainly, although we have no idea why it works, physical activity seems to be the closest thing we may have to a wonder drug so far. Lots of study looking at body weight, and this is kind of the other side of the coin to physical activity. It mainly comes from observational studies, but because body weight is collected on almost all of these surveys, we have a tremendous amount of data on it. Again, not clear why body weight is associated with colorectal cancer risk. We do see a dose effect. So for people who are just slightly overweight versus people who are obese, the risk goes up. It's thought maybe to relate to insulin or inflammation. And we usually measure this by the BMI, which is your weight over height squared. And I just gave some numbers of what overweight and obese would be considered based on average height in men and women. So alcohol use, again, comes from observational studies because almost all of these cohort and case control studies asked about alcohol. We have a lot that have studied in the past. The mechanism is not known again. That seems like a recurrent theme, but it's thought to have to do with folate. Alcohol drinking chronically will reduce folate. And again, here we're seeing kind of that dose response where the more you drink, the higher that risk goes. based on the effect size. Again, relative risk being people who don't drink at all versus people who drink 3 drinks a day versus people who drink 4 drinks a day. Tobacco is another one that's been a lot of studies in the same issue that we see, an 18% increased risk, where there are lots of carcinogens in tobacco smoke. Interestingly enough, and we won't get into this, but there's 2 major pathways for cancer development. One is called the serrated polyp versus the traditional adenoma carcinoma sequence. And this serrated polyp seems to be a little bit more linked to tobacco. And then finally, medications. So aspirin has been the most studied. And again, these are studied primarily in the adenoma setting. And there have been 4 clinical trials that have shown that you could reduce your adenoma risk by anywhere up to 17%. So very effective data of reducing adenomas. Ideally, we want to know about what happens with colorectal cancer. Only 1 study, which was null. The dosing was every other day, so there's, again, concern that it might be a dose effect. Maybe the study wasn't long enough. So there has been some concerns on whether this trial, there were other reasons for it to be null besides that there's not an effect. There's been a lot of studies in heart disease with aspirin. So when we look at those studies and look folks who were given it originally for heart disease to see about colorectal cancer mortality, you see a pretty substantial reduction. So aspirin tends to look pretty effective, but as I'll talk about just right now, there are some concerns with it. So aspirin, the data on aspirin has been so convincing that the United States Preventive Services has for a while recommended using low-dose aspirin for cardiovascular disease, but just recently kind of amended that to also include people who may benefit it for primary colorectal cancer prevention. And in their recommendations, they're saying individuals who are aged 50 to 59 who have about a 10% or greater risk of developing heart disease in 10 years, they're not at increased risk of bleeding, and have a life expectancy of 10 years. So they add a lot of conditions to it. But if you look at this chart, and this is men, and the next slide is women, it's a modeling of what would happen in people who have heart disease as that risk goes up, and if they take aspirin. And what I want to show you that's most important is really what you're seeing in aspirin is a big reduction, these big numbers in the non-fatal MIs. When you look at how many estimated colorectal cancer cases are prevented, it's a big number, but it goes down. But what you really should also look at is right here. So with aspirin, this has been our big concern. So you actually have more serious GI bleeding than you have colorectal cancers prevented. And this is, for the longest time, kept it out of general recommendations of saying everybody should take aspirin for prevention. However, when you kind of lump it together with what you're getting out of cardiovascular disease, it makes it a more favorable balance. And here's women too, where you'll also see in women, again, much more GI bleeding than cancers prevented or even MIs. But when you kind of put the two together, you start seeing that the benefits outweigh the risks. And then I'll just very briefly, hormone replacement therapy has been studied in randomized controlled trials. Looked like it could reduce risk, but there's a lot of other concerns related to increased risks of breast cancer, heart disease, blood clots, so it never really got recommended. So I just made this table to give you kind of to put everything together, these relative risks and where they work on. And you can imagine this side is where you're going to decrease cancer. This is increased colorectal cancer risk. And I just kind of lop things in where they relative position. The ones in red are ones where observational studies have said they're positive, but they're null on randomized controlled trials. So you may want to just kind of be colorblind to those. And this is the biomarker fish, which I think is too small to really probably make too much out of. But as you can see, again, screening seems to rule the roost. Aspirin, where we're getting certain recommendations in the right population, and then there's other lifestyle interventions, although they're smaller on it, these are also going to be beneficial for other health conditions. And then, of course, increasing risk here with the risk factors we talked about. So when you're diagnosed, so when you want to know about reducing your risk of a second colorectal cancer, here the data is much, much less. There's a lot less data on lifestyle. In fact, there's a lot less data on surveillance. Right now, it is believed that in individuals who've been diagnosed with colorectal cancer, it's surveillance that is going to be your best option. So in other words, yearly colonoscopies. And these are individuals who don't have genetic syndromes, but yearly colonoscopies until they're normal, then every 3 to 5 years. And it looks like from, again, observational studies, not randomized controlled trials, that this could be associated with a significant reduction in risk of colorectal cancer mortality. Again, these guidelines are still being worked on. As far as lifestyle factors related to cancer survivorship, again, we don't have as much rich data as we do in primary prevention. So there's limited status, but when you look at dietary patterns, what's considered the Western diet, so this is high in saturated fats, high in simple carbohydrates like your sugars, or red meat, less vegetables, that seems to be associated with an increased relative risk of recurrence in stage 3 disease, so almost 185%. So that's a pretty stout increased risk. As we said before, a lot of these things cluster together as these behaviors. So physical activity kind of has the opposite effect. Looks like it reduces this risk of recurrence, again, from observational studies. And then obesity, as far as the flip coin of physical activity, is associated with prognosis. So it looks like, although we have more data for the primary prevention, some of these secondary preventions are going to be similar. And because we're running out of time, I'll just flip through this, but this is just some of our recommendation on polyps. And this is secondary prevention related to individuals who have polyps, but not colorectal cancer. And these are those studies that I've talked about already. As we talked earlier, aspirin and calcium looks like it prevents recurrence. Physical activity looks like it can be beneficial, and the antioxidants look like they did not have an effect. So I want to finish it up because I think I talked longer than I was supposed to. But and we want to have time for questions. But there are ongoing studies going on and novel therapies in the development. As far as the omega-3s, there are 2 clinical trials ongoing to look at these with an outcome of colorectal cancer. And they're much longer trials. There's a study looking at vitamin D at the higher dose. There's been a recent study that suggested that metformin, which is the medicine we use for diabetes, at lower doses reduces recurrent polyp formation. This was a randomized control study. And then some other agents, DFMO, which interferes with this polyamine synthesis, and an NSAID, Sulindac, also, at least in this initial study, looked like it had a profound reduction in recurrent adenomas, but still needs to be followed up on. So I kind of went through that pretty quick at the end, but I did want to leave a little bit of time for questions. And let me see if I have that last slide. I think that's it. Yes, questions.
Thank you so much, Dr. Murff. I'm going to pull up some questions now. So we did have a couple questions come through. Let's go ahead and start with, we have this one about curcumin or turmeric, asking about whether or not it's a chemopreventive agent, and I guess talking about herbs and dietary supplements in general. Any information on that?
Yeah, so that's a good point. And when I showed you the pyramid, what I didn't put on there, and some people have put at the very bottom, is animal studies and cell lines. So a lot of the initial data that we get on some of these dietary supplements and herbs comes from mainly animal studies and cell lines. And so what we really want to do is see, well, how does that work in human? There are some ongoing studies of turmeric, I believe, looking at in humans. And the way those usually work, the early studies, what they'll usually do is they'll give people some type of a supplement, and then what we'll measure is what we call a secondary marker. So again, what we're really interested in is what it does with adenomas, what it does with colon cancer. But because it takes so long, and when we're at the early phases of investigating it, we'll use what we call a secondary marker. So we might take a biopsy of the colon and see what the cells look like they're doing. There's debatable how good that is in predicting cancer risk. So the bottom line is there are some animal studies that look promising and some early human studies with these secondary outcomes. What we really need to do is look at a larger study where we're looking at more hard outcomes. I'm not aware of a study currently ongoing using turmeric, but I think there's certainly a lot of interest in it. But at this point, when you look at kind of what data we have, it's still pretty in its relative infancy.
Thank you. So that brings up another question in terms of, people going out to buy supplements and adding additional, vitamins to their daily routine. Is it more recommended to do that, or to get the food the vitamins and supplements naturally through your food. I imagine that's a conversation to have with your doctor. Is that correct?
Yeah, I think so. I mean, so most of the data, as you probably saw as I went through the slides, the observational studies initially show benefit from the food source. And then when they try to replicate the study giving the supplements, they don't see it. And so this has come up with a lot of things. We saw this in many other conditions, not just colon cancer. Vitamin E is notorious where it just didn't seem to work when you gave it. So that does bring the question of, is there other factors in the food that might also be beneficial? Is it somehow the way that it's delivered? So at this point, when you're thinking about that, I know it's easier to get it in a supplement form, but most of what we have as far as the data really comes in the dietary form. So it seems as if until we know what it is in that formulation that works better, I would probably say go for trying to get in the diet first. Obviously, that's not going to be feasible for everybody, and you may just want to talk with your doctor and see if they can kind of go over the risks and benefits of these. But right now, so far, what we tend to see is when we take a food that looks like it's been useful in studies, then try to boil it down to a supplement, that supplement tends to not do what we hoped it would.
Right. Well, great. Thank you. A couple more questions here. Infant aspirin versus the typical aspirin. Is that the same effectiveness, or have any studies been done on infant versus the regular dose?
Oh, that's a great question, and there is a lot of interest in the dosing to look at these two dosing strategy. In fact, there was one of these adenoma studies. Strangely enough, the lower dose, the infant or baby aspirin, 81 milligrams, seemed to be effective, while the higher dose was null. And so everybody was really scratching their heads on that. So there's a big question on the dose. We tend to believe that we're going to have less side effects with the baby aspirin, so that's why we tend to steer there. There's certainly no data to suggest that a higher dose is better. It does seem like aspirin, the duration may be important. It may take a long time for to get this benefit, which is, again, the reason why there's some apprehension about starting it. The reason why when I showed you those guidelines, they're very complex, because, if you're going to take it for 10 years, the chances of having some type of a side effect from it could be high. But that being said, at this point, there's no data to tell one versus the other. It looks as if they're both relatively equivalent, although, as I said, the one clinical trial suggested that maybe baby aspirin may be more effective. There are some ongoing studies to try to look specifically at dosing to answer this question. And again, the focus is on, we really want the lower dose, just because we think that's going to be associated with lower side effects.
And Dr. Murff, is that in relation to preventing recurrence and new polyp formation, or have the studies just been in terms of reducing colorectal cancer risk in general?
So for new polyps, so most of those studies have been for recurrence, adenoma recurrence. So in general, the way they do these studies is they will get somebody who has seen their doctor because they have a polyp, and they'll recruit them at that point. And then when they come in to get their follow-up colonoscopy, they'll see whether it's made a difference. So again, all of this is in recurrence. Some of it, because it's aspirin, and because aspirin has been used so heavily in cardiovascular studies where they have hundreds of thousands of people, they will go back and look at these studies because a lot of them recorded if somebody developed cancer. And so some of it comes from this kind of secondary analysis. As far as primary prevention, or even looking at people who have cancer and reducing the recurrence of cancer or a second cancer, there's much more limited data on that.
Wonderful, thank you. I think we have time for perhaps one or two more questions. I have a question here as it relates more to, I suppose, the research process. You mentioned that interventions around lifestyle and behavioral changes require huge sample sizes that might be difficult to obtain. Within the research institutions, do folks typically work together, say across the country, or to gather those sample sizes?
Oh, absolutely, absolutely. You're right. In order to do a study like that, you have to do it multi-center. And some of those fiber studies and the other supplement studies were all done as a multi-center study. So you're absolutely correct. One place couldn't recruit that because it just usually requires a lot of people. and most of the well-done ones will have people from multiple centers. Even if that last slide I showed you, where I showed you some ongoing study, all of those are multi-center. Sometimes they'll have, over 100 different centers involved trying to recruit people.
Great, thank you. And then final question, again, coming back to the metformin and aspirin combination. I know you spoke a little about this towards the end. Now, are those studies currently being done, or what? I mean, how would you talk to a patient about this, trying to get more information about whether or not that's going to be beneficial for recurrence?
Yes. So for metformin, it's more straightforward. Metformin is, there's been a lot of excitement about it. It has a lot of properties that makes it look like it could be beneficial, and a lot of observational studies that have suggested it might have an effect. And now we even have a randomized control trials for adenoma recurrence. But we just have one, and so you don't want to rush too quickly. And again, this medicine is made for diabetes, so we don't really know what happens when you give it to people who don't have diabetes. So this is, I think, from a metformin standpoint, I think you're still going to have to wait and see. And there are a lot of studies going on because, as opposed to, as we talked earlier, at lifestyle interventions, it's pretty easy. You can just give a person a pill. But there's a high safety bar. So oftentimes when we think of preventive medicines, we're thinking of something that I'm going to give somebody to take for maybe several years to prevent a condition that maybe they weren't going to get in the first place. So you really have to make sure you have a solidly safe intervention. So metformin, the data is definitely not there, and I don't think anybody's really thinking of using it that way. Aspirin's a different story. Aspirin has some pretty convincing data, and I think you just have to factor in these other issues that the United States Preventive Task Force mentioned, mainly like, well, what's the likelihood of this person having bleeding? What's their comorbid other illnesses they may have? Could this also give benefit besides that? But the aspirin data looks pretty convincing. I think at this point what we're trying to do, a lot of the research community is looking at ways to get the benefit of aspirin while minimizing these side effects. So could it be dosing strategies that are a little different, or maybe the lowest dose you could get, or maybe aspirin combined with something else to help kind of a little bit of both might give you this protection and lower it. So the aspirin's pretty compelling.
And we have, I think, just one last question came through. You discussed observational cohort and clinical randomized trial, and there seems to be a difference in the outcomes. Is this why we often read and hear a lot of contradictions within the outcomes?
Absolutely. So that's a great question, and I'm so happy somebody asked that, because I just want to make you realize that the medical community, we don't completely not know what we're doing and just keep changing our mind. What happens is, because the case control studies can be done relatively cheap and relatively quickly, that data gets generated first. So all of a sudden you can get a lot of these studies that have a lot of bias, let's say. So if I'm interested in studying the effect of green peppers on something, and people who eat green peppers also eat a lot of vegetables and fruits, and they go out and they exercise every day and they never smoke, and so I'm getting this false assumption that it's related. Well, maybe that's going to make news, and so all of a sudden it's all over the paper saying, oh yeah, you got to do this, you got to do this, you got to do this. And then the cohort studies are more expensive. They take many more years to finish. They start saying, well, we're not seeing this effect as big. Maybe there's something there, maybe they're not. And then the most expensive is the randomized controlled trials, and then those will come up after years and years, and then you'll have something that traditionally from the observational studies you thought were effective turns out not to be. I mean, there are some folks who have definitely called, have suggested even limiting how much observational studies are. The reality is they're very useful because there's some data that you can't get at. For instance, smoking, never be a randomized control study. All of our recommendations from smoking are from observational studies. So they play a role, but oftentimes that's exactly what you're seeing, those contradictions. The first study came out, was easy done, probably the lower quality evidence. Takes a while for the higher quality evidence to generate, and then it's what we call the winner's curse. And then the second, other studies look like it's not as important, but it results in some contraindications.
Yeah, great. Well, thank you so much, Dr. Murff, for taking the time today to present. We really appreciate it and your expertise. And thank you to all the listeners out there for joining. And I hope you guys all have a wonderful day. Thank you.
Thank you so much.